Fantastic stuff. So we can see a few people coming on in to the webinar, which is brilliant. Welcome everybody. So much easier doing this virtually. We don't need to sit people. We can just have them come in and they can just find their own space. It's absolutely brilliant. Great stuff. So before we start, if everybody is able to cameras off and mute for us, that would be fantastic. But welcome everybody. I hope you're all very well. And again, welcome to today's webinar exploring the role of aerobic exercise in managing fibromyalgia. And May is, of course, Fibromyalgia Awareness Month. So I'm sure this will be of real interest to many people here today. Joining us today, we have the author of a recent systematic review and meta-analysis published in the EJP, the European Journal of Pain, alongside a representative from Pain Alliance Europe. And they're going to be discussing their perspectives on this topic. It's going to be a real fruitful discussion. So thank you so much for joining. I'll give our panelists, you might be able to see them on the screen, a chance to introduce themselves just in a very short minute. But first, let's quickly mention on how you can kind of engage and benefit the most from this webinar. Like all of the live webinars that we provide, there's a live Q&A function at the bottom of your screen. Please use this to ask questions. You can also do that anonymously if you want to. And we'll get to as many questions as possible. We'll do that at the end of the webinar. We're going to go through all of the questions after the presentations have been completed. There's also a chat function. You can use that for general comments if you just have any opinions that you want to share, but it's not specifically a question. Please feel free to pop it into the chat there. A reminder also that this is a recorded webinar, so you can access all of these discussions, of course, not in a live format, at a later time if you wish to do so via the EFIC Academy and social media. We share it on there as well. Okay, that's enough of talking from me, I think. But again, welcome everybody. Housekeeping out of the way. So you know a little bit more about how to take advantage of the panelists being here. So I'm going to first hand it over to David. Good morning, David. Thank you so much for joining us. Would you be able to take us through, of course, your presentation and also give us a little bit of an introduction about yourself? Welcome.
Thank you very much, Nathan, and to the EFIC for having me here. By myself, I'm right now PhD student and teacher at the University of Cordoba. I'm a physical therapist, and I'm working in researching about fibromyalgia right now.
Fantastic, and thank you so much for joining us. Would you like to share your presentation? We'll go through, and then we'll have an introduction to Nadia afterwards.
Sure. Shall I share in the...
Absolutely. If you want to try sharing your presentation, or we'll see where we're at. We'll take it from there.
Give me 1 second.
No problem.
It should be in the screen right now.
Absolutely. That's brilliant. Thank you so much.
Okay. Shall I stop sharing, or shall I begin with my presentation?
Yes, go ahead with the presentation. Thank you.
Well, thank you very much. What I said is thank you very much for having me here. I would like to apologize for my English because I'm not a native English speaker and I can barely speak my own language. So it's going to be interesting for me to be here, but I'll do my best to keep up. Well, as we said, May is the awareness month of fibromyalgia. So let's start with the basic. As fibromyalgia is a chronic pain condition that is broadly spread worldwide, with a prevalence between 2 to 4% of global population. The most of the population are women, as we may know, but we have males as well. This condition, the symptoms that characterize it are obviously pain, which is I think the cornerstone of this pathology. But we have some physical symptoms as well, like fatigue, insomnia, and stiffness, and some psychological symptoms, which is with a lot of symptoms like anxiety, depression, and cognitive impairment. In this regard, if we take Europe, for example, which is almost 750,000 people, 750 million persons in Europe, fibromyalgia will be present in at least, with this prevalence, between 40 million people and 30 million people which the vast majority of it being women. And I think that's a lot of people with a pathology. Uh, with with that, taking into account that many people that have fibromyalgia, uh, we should take a look at the risk factors for developing it. The first thing that we can take into consideration is that female population have more fibromyalgia than male population, and this prevalence range between 60 to 90% in this people in these patients worldwide. And we have another risk factor. The background of the presentation is a image from the review from Francis Crick from 2020 that they research about the risk factors for this population, and we have that having another comorbidities. Uh, it doesn't matter if there are musculoskeletal or another type of pathologies. It's a big risk factor for it, as well as the age. As we may see, fibromyalgia is more prevalent with the age. And in a study based on a Spanish population, uh, they observe they see that an early onset of the symptoms was positively associated with the later development of fibromyalgia, which makes sense as we said that the prevalence increased with the age. Another risk factor that isn't really present here, but it's a risk factor for this population, is that uh, having kind of PTSD, the post-traumatic stress syndrome, or having traumatic uh, trau- sí, childhood trauma tends to, well, sorry for this. Having childhood trauma is another risk factor for the development of fibromyalgia. With that into mind, we have to take a look of the cause of the pathology. I'm presenting here three studies, very simple, based on European population. The first one, it take a look on is a systematic review, taking into account European population, and they range the direct cause of the pathology, direct cause from visit to the doctor and medication, in a range of almost 1,100 to 7,500 of euros. In another study based on Spain, they estimated the annual cost in both direct cost and indirect cost. It raised the cost a little bit from almost 9,000 to almost 22 and 500,000 euros. Taking that into account, taking into account that uh, in another study and a Danish cohort study, that patients with fibromyalgia tend to, at least in this cohort, the half of this population were receiving disability benefits 10 years post the diagnosis versus only an 11% of the general population. uh, we can see that this is a pathology that not only affects the life of the patient that are having that are suffering the pathology, but also affects everyone because it has a very huge cost. With this into mind, how do we treat these patients? I'm presenting here only two studies. The first is an study from 2017 from the European League Against Rheumatism, which is a clinical practice guideline, uh, and we can see that the first line of treatment should be patient education and information. Later on, we should engage in physical activity, in physical exercise, and later on we should go to if we didn't meet the improvement, if the patient didn't improve enough, we should keep with some tailor some individualized treatment. Taking into account that, as we can see in this recommendation from the pharmacological management, only aerobic and a strengthening exercise uh, goes to a strong recommendation. So this should be a first line of treatment. Another study, another consensus, another clinical practice guideline, this from Egypt, uh, very 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 simply said, I'm going to read it. Initial management should focus on non-pharmacological therapies, as well as we have said in the previous study, based on its availability, its costs, and patient preference. And the patient should be encouraged for great incremental aerobic and strengthening exercise. As we've seen with these two studies, uh, aerobic and strengthening exercise should be a first line treatment. With this, we have a at least we have a question that, okay, we know that patients should do aerobic exercise, but how much should they do? Because it's not discussed here. With this in mind, is where our study that Nathan previously highlighted starts. We conducted a systematic review with a meta-analysis about the topic. We take a point from previous study that stated that a clinical relevance improvement in this patient should be from 1 to 2 points in a 0 to 10 scale. We take the mean of that, and we set a point of improvement on 1.5 point of improvement to be clinical relevant for these patients. With this, we conducted the meta-analysis and see what was the dose of exercise necessary for this. In this regard, if we take into account first the frequency of exercise, how many times per week should a patient do aerobic exercise? What we saw is that from 2 to 3 times per week was the only frequency that reaches this minimally clinically important difference that I've just talked about. Uh, and problem a problem, yeah, that we saw here is that although we can reach it with 2 to 3 times per week of exercise, uh, when we see we don't have enough studies in lower frequencies, 1 time per week, for example, that we only have one set of data. But when we go beyond 3 times per week, we don't have enough studies of this. And taking into account that the World Health Organization, sorry, I tend to mispronounce that, when we take into account this recommendation that people in general population should exercise in a cardiovascular way from 3 to 5 times per week, we need more studies in these higher frequencies to really see what happens. Later on, we ask ourselves, okay, 2 to 3 times per week of exercise, okay, perfect. How intense should I do that? In this regard, we take the mean intensity of these studies, with which was typically expressed in a high rate or VO2 max, but we summing it up into light, moderate, and vigorous intensity. And we saw that the only intensity of exercise that reached this point of improvement in this patient was a vigorous intensity. Vigorous intensity can be classified with in this regard, uh, like 75% of heart rate max and beyond 60% of VO2 max. These data are taken from a study from the American College of Sport Medicine. Well, we take that point. As from the type of exercise for the patient, we have a lot of data. We have different type of exercise. In this regard, we found that pool-based swimming and walking, it doesn't matter if we're outside in the streets or in a park or working simply in a treadmill, reached the point of improvement in this patient. But we have to be cautious with that, because the vast majority of this data is based only on 2 to 3 studies at most. For example, swimming only have one study. So with the type of exercise for this patient, I think that the best thing should be to use a type of exercise that the patient likes and the patient can do. It doesn't matter the type. I think that the better recommendation should be to go or to progress to more of a land-based exercise as the patient progress. But the key point here should be the adherence of the patient, because all exercise will be good if the patient do it. If the patient don't want to engage in walking or in pool-based exercise, it doesn't matter how good this exercise will be for them, because it's not gonna go anywhere. Another important factor: how much time should the patient be exercising or engaging in this activity to reach this improvement? Uh, we saw that at least the patient should be exercising for 6 weeks before it start to improve. But anywhere from 6 to 12 weeks will be a good starting point. Although the recommendation should be for the patient to keep exercising for his whole life, if possible. Another question that we have: okay, I have to go with a vigorous intensity, 2 to 3 times per week. How much time do I walk for each session? In this regard, we found that for each individual session, the data ranged from 25 to 40 minutes of session. Although 25, for example, the 25 data is only based in one study, and more minutes or more volume of session, like the 45 minutes, is as well based on one study. So we should keep studying this, and we should keep trying more minutes or less minutes, and we need more data as well for the the weekly, pardon, the weekly volume of exercise. uh, we should at least exercise for more than 100 minutes. But as well, it will be nice to see more studies coming forward with more minutes of exercise, as the general recommendation for general population is above 150 minutes. So it will be nice to see more studies in this regard. Later on, and almost finishing this presentation, when we talk about the progression of how we progress the exercise, in the studies that we research here, we only found a little data in this regard, and only the intensity progression in intensity over the weeks uh, was the only way of progressing that reached this improvement in this patient. Although it's only, as I've been saying, it's only that based on 2 studies. So we should keep studying this and keep trying different things. Later on, to sum it up, uh, as I said, we need more studies in this regard. We need to keep studying. We need to try different things. But when with what we have here, uh, the frequency patients should exercise at least 2 to 3 times per week for at least 6 to 12 weeks for start to seeing improvement. The intensity of the exercise, I would advise to start light, because some patients maybe exercising previously to the intervention, but some of them maybe sedentary. So we can start with a vigorous exercise in them. We should start, as I said, light and progress it over the course of the 6 to 12 weeks to give the improvement. The type of exercise should be based solely on personal preference of the patient, and the accessibility to do it, because as swimming should be very nice, but if the patient don't have a pool next to him, it won't be able to do it, so we can do another things. As well, for the volume of the exercise, a patient should do at least 25 to 40 minutes per day of exercise, or more than 100 minutes weekly. So thank you very much for your attention, and thank you very much to the FIC for having me here. I will gladly answer any question that you have. Thank you very much.
Fantastic, David. Thank you very much. And I think everybody would agree. Fantastic English. Very, very understandable. So well done there. Absolutely brilliant. Thank you so much for sharing that. Okay, brilliant. So just a reminder, thank you for the questions that are coming in. Brilliant stuff. We can see a couple of questions. Just as a reminder that you can do this anonymously if you wish, even if you have a talking point that might be of interest to everybody. We do have a bit of time to discuss at the end. So any thoughts, comments, questions are most welcome. Of course, we'll do it after we have a presentation from Nadia. Nadia, welcome. It's great to have you here. Thank you so much for joining us. Would you like to go ahead and share your presentation and, of course, give us a little introduction to yourself? Thank you so much for being here.
Yes, I will share my presentation. A moment, please, to be sure that it's here. And can you please let me know that you can see it?
Absolutely. Thank you.
Okay, so thank you. And let me briefly introduce myself. I'm Nadia Mayu. I am the current president of Pain Alliance Europe. For those of you that do not know Pain Alliance Europe, we are an umbrella organization of other member organizations located across Europe. We are representing roughly around 40 member organizations from 17 European countries that are focused on pain, mainly chronic pain, but we don't really pay any attention to the primary cause of pain. It could be primary or secondary chronic pain, so we don't care about the cause of the pain. That's a little bit about me. Maybe I should mention that I am a cognitive and experimental psychologist doing my PhD, but that's irrelevant because I'm actually a chronic pain patient myself, and this is quite relevant for what we are about to discuss. This is a really nice occasion having to go second to the article that was really nicely presented and with really a good English by David, who was a bit hesitant and saying, oh, my English is not really good, but it was actually really good. And talking about exercise and how it can help reduce pain in fibromyalgia. Yes, the research is there and it can actually offer pain relief to fibromyalgia patients. And we do have now the recently published article that aerobic exercise is really a beneficial type of exercise for this type of patients. So we just briefly to comment on the societal impact of pain, the burden of the book of evidence that SIP introduced to us like last year, and I hope if not all of you, just like most of you have heard or like taken a look at it, or maybe even use it as a resource in your clinical practice, or if you're from the patient community, you are using it among your organization. This is one of the infographics released by SIP, and it's talking about the prevalence of pain. So we can have lots of information just by looking at this infographic, but I want to focus on the chronic widespread and the fibromyalgia information we do have here. And as David already mentioned, it's not the most common type of pain, not the most widespread across the world, but it's quite impactful, and it is affecting the lives of too many people across the world. And it involves widespread pain, fatigue, sleep, and memory issues. And the thing that's really, really important with fibromyalgia is not only what type of pain it is, because it's involving the central sensitization pathways. It's also the impact and the diagnosis issues that are always involved. And as I mentioned, because I do a lot of volunteer work with a chronic pain clinic, and whoever works with fibromyalgia patients really knows uh, how um, how much trouble someone has to even get the diagnosis of fibromyalgia, and how many doctors one has to go through until he gets there. So moving on, and like taking a look at again the same resource, the SIP Book of Evidence, we did see a few testimonials, because that book really delved deeper into the specific categories of the impact on the life of patients, the biggest challenges, the pain sensations, and the mental health issues patients do have to face when living with pain. And apart from anything else, patients living with fibromyalgia, and at this case, it was a male patient saying that living with fibromyalgia has one of the prominent features is the isolation, and not having a normal life, and feeling like there's no future because there's not a lot of support due to the lack of research. So that was already mentioned in the previous presentation by David, so I don't want to say a lot of things about that, but isolation means you're staying a lot in, you're not having a lot of social activities, you don't go a lot out of the house, and isolation is usually is interlinked and closely related to a person being sedentary and staying home and sitting on a couch and not moving around. So we are here to discuss about uh, moving around and exercise. So the pain experience of a patient living with fibromyalgia, so the nature of pain. People talk about burning pain, a stabbing pain, or an aching pain with a variety of intensity. And that pain is fluctuating between days, and the pain is always there, and it can also flare up and always go higher and sometimes become less. But when it's flaring up, it goes even higher. So living with fibromyalgia, patients experience frustration from treatments, or if they haven't gotten a diagnosis, they are going, as I said, from doctor to another doctor, and they don't get a proper treatment. The pain may be underdiagnosed or misdiagnosed, so there's not even a proper treatment, and there is a limited pain relief. So the invisible nature of the condition can lead to misunderstanding, and there is already, probably you already know that, a misconception regarding the fibromyalgia patients. You all know that until recently they were firstly referred to psychiatrists, and after that to any other doctor, which we now know that this is incorrect, and a psychiatrist is not the proper or the first doctor a fibromyalgia patient should visit. So regarding exercise, patients report feeling more energized and less stiff after regular exercise. It's like similar, this is something that came out from David's research and like the review we just saw, and that there is gradual improvement in daily function and in the quality of life of the patient. But there are challenges that are faced when someone is trying to exercise or has inserted exercise, daily exercise or regular exercise in his or her life. So there is a difficulty in starting an exercise routine due to fatigue and pain flare-ups. So imagine from a patient being sedentary and sitting all day or not moving, and we have to always consider that the patient is not just being stiff and staying there, but there might be, we usually have the presence of a mental health issue also, probably a depressive state being present. So this is a demotivating state for the patient. So the starting step, the moving out of the couch and getting out and getting that exercise is not only getting out and like defeating the fatigue or the pain, but also the depression that might be and coexisting with fibromyalgia. And then after doing that and getting a move and a start on, you have to persist and be consistent, as already mentioned in the presentation before, which are key in managing expectations and what's going to happen. And I think, and maybe we're going to discuss it in a little bit, someone already asked, and what about, and the fear avoidance behavior, and what about the kinesiophobia that might already be there? I mean, what about if I exercise too hard or if I strain myself and I get injured? And what about that? Which is let's face it, these are also thoughts that are present in a chronic pain patient in terms of what's happening on a cognitive level when you're living and you're faced with chronic pain. This is what a CBT therapist always has to face. The catastrophizing, the fear and avoidance behavior is always present, and you also have to include that when you're trying to motivate something, and we have to always account for it when we are discussing exercise, which is movement, which is something that could also trigger the fears of what's happening and what could happen to me. So preferred, as mentioned also, preferred exercises are walking and swimming and cycling. These are low impact exercises and exercises that are not actually harmful exercises if done correctly. And some patient-friendly tips among the communities of patients are to start slow, go slow, and build up from there. Listening to someone's body is a really common thing among the patient communities. I mean, when you have a flare up and you know that this is not your day or maybe your week, you should like cut down a little bit, which is not really aligning with whatever David was mentioning, because being consistent and persistent with your exercise sometimes is not aligning with what your body really wants. But this could also be regulated and could be in a way accounted for, and it's when it is individualized, and I'm going to talk about it in the next slide. And someone has to set realistic goals. Not everyone can do everything, and this is real not only for fibromyalgia patients, but especially when dealing with chronic pain. Someone should absolutely keep that in mind. And of course, pacing ourselves is absolutely necessary for doing anything when you have the basic issue of chronic pain in your life. So for anyone in the audience living with chronic pain, that's a really known concept. And then for everyone that's dealing with chronic pain patients, I'm absolutely certain that you have already, in a way, discussed it with your patients and the people you are dealing with. And then safety and adaptability, because we are talking about aerobic exercise, um, tailored to individual needs is generally safe for fibromyalgia patients. And in general, exercise should be individualized, considering preferences, skills and tolerance and fitness level from every patient. And strategies that can be used and can lead to successful exercise programs is, as mentioned before, consistency over intensity. So a program of to the end of what David was discussing right before me is a way to do it. Tracking progress, I mean, that's quite useful in chronic pain in general, like even with tracking your intensity of pain, how much steps did you do, how many exercises did you manage to do. This can inform your progress, or it can even inform how much your body is it's talking to you and how much you can do or you should not do at particular periods of time. And mindfulness and relaxation is really useful because you always need to be aware of what you need on the other side of exercise to balance it out, because it's a matter of balance either way. You exercise, then you need to cut back. And before closing my presentation, I need to just mention some barriers which are, I think, quite common, and these are the reasons for someone not getting exercise into their lives. So the flare-ups, I've always talked about them. The fatigue, which is always there, this is quite common, quite persistent, and quite creeping into the daily life of a person. So it's really, really useful for everyone to be aware. So apart from the motivational issues I've already discussed, the fatigue is something we all need to be aware of, and that's a hallmark for fibromyalgia. And this is something we also need to maybe account for when building an exercise routine uh, uh, ac- along with the motivation. Also, lack of understanding. Sometimes fibromyalgia patients do not or are not fully aware of the benefits of exercise, especially the aerobic activities. And maybe the HCPs, the healthcare professionals, do not exactly explain or communicate how beneficial and how much they could gain out from exercising. And then lack of proper treatment when the pain is suboptimally managed. It is like we have a tank, some tanks one close to the other. So when you are in too much pain, and then the probability is that your depression is higher, and then your motivation is lower, and your fatigue is higher. So we need, this is a continuum. We need lots of things to align well so we can exercise more. I know this is like to close in a more optimistic note. There are things to be done. I mean, alternative treatments such as psychological interventions and um, some lifestyle changes could also be beneficial. So combining all together with exercise could absolutely work really well for fibromyalgia patients. So I think I've covered everything, and my key takeaway messages for today is that yes, we do agree, and from the patient perspective, aerobic exercise can significantly reduce pain. And with the right approach, every patient can enjoy the benefits of physical activity in general, and persistence and gradual progression are essential to success. So thank you very much.
Thank you, Nadia. Very, very interesting. I think the two presentations complement themselves very, very well in that we're trying to develop this conversation about, where does the literature stand? What is actually required of people living with fibromyalgia? And then what can clinicians do feasibly within clinical practice to help people living with this, and obviously in the context of pain management. But thank you so much for your presentations. We do have many questions, which is brilliant. We have about 20 minutes, 19 if we want to be precise, to go through these questions. If anybody has any comments, please feel free to throw them in. We'll try and get through as many as possible. There seems to be, quickly, before we get started, I want to bring someone else into the conversation. Kate Forster, thank you so much for joining us. It's brilliant to see you. Thank you so much for being here. Would you like to give a quick introduction to yourself?
Thank you, Nathan. That's so kind. I shall try and take not too many of our precious minutes, as it's wonderful to see we've had nearly 100 people here today to discuss fibromyalgia, and David and Nadia's most excellent presentations. I am a colleague of Nadia's as another person living with a long-term health condition and a member of the board of Pain Alliance Europe, Lipedema UK, and the Lipedema World Alliance. So I'm delighted to be here. A number of people with lipedema also have a fibromyalgia diagnosis. So I was making notes in David's presentation and sharing them with my colleagues already. So thank you for letting me introduce myself. And I can't wait to see some of these answers on these great Q&A questions.
Brilliant. Yeah, thank you so much for taking time to be here. Speaking of which, let's get into the questions. There does seem to be a few of them which kind of draw into the points that were made towards the end of Nadia's presentation about, it's very, very clear that there's, as May mentioned there, is this sense of danger or injury or apprehension to undertake something like physical activity, aerobic exercise. Juan Yu, please, I hope the pronunciation is well. The negative of being English is the pronunciation of really, really beautiful names is completely lost on me. But they mentioned there about, the paradox of not having good adherence to the beginning of these types of exercise prescriptions leads to dropout. And how can we address that, I guess, from a clinician's perspective and a person with lived experience perspective of, it's all well and good that we need this aerobic exercise and we know the core components of that, but how do we address those flare-ups, those really tough times of the initial adherence to something like an aerobic exercise program? David, perhaps you can lead on this.
Yeah. So the first thing should be patient education, to explain to the patient that the flare-ups are normal, are typical in the beginning of the exercise, that with time they will be better, and they will experience less flare-ups and less pain. But I think that the initial course of action should be the education, not to start engaging in a physical activity or in physical exercise without explaining to the patient what to expect.
Yeah, Nadia, how is your experience for people with lived experience? And this education is the apparently the core component, something that needs to be addressed from the initial stages.
Well, I have to give my answer in threefold. So the first, as a patient, they are quite right to ask that, because yes, at the beginning it could get more painful, and then it will subside with time, because let's take a patient who hasn't exercised for some years or at all in his or her life, and begin at any level with any type of exercise, then you will have, apart from the original cause of pain, whichever it is, like fibromyalgia or fibromyalgia plus any other cause of pain, you will get sore muscles because of the exercise. I mean, even the slightest exercise, you are bound to have a little muscle pain because of the exercise, and that might trigger your fear of harm, your fear of whatever could possibly get worsened. And because of the central sensitization, you may even experience a heightened sense, like the hyperalgesia. Someone I saw discussing. Sorry, I'm not seeing it right now. And this could even level up the pain feeling, the sensation of pain. And that way you will start thinking, oh my God, exercise is more painful than I thought, so I should stop immediately. So probably at that point, whoever is working with you doing the exercise, so it's the gymnast, the physio, your doctor, someone, as David said, the patient education should be well behind you or around you to explain what's happening and ease whatever thought processes are happening in terms of phobias triggering and thoughts triggering your catastrophizing process, saying, oh, if I do it again, then it will be even worse. And if I do it again, it will be even worse. So let me stop doing it altogether. See, so this is kind of building up, and if you let it build up, it will like the result will be you leaving it from the first time. So this is kind of the patient education thing that probably David is mentioning, and this is what we are doing. Like we are trying to explain, even at the cognitive level, what is happening, and that is quite reasonable to think that that way because you are okay. It's a pain level up, but then it will come down, and it's normal because it's a muscle. It's not harmful. It's okay. It can happen, and this is how to approach it. If you don't have that and you do it on your own, then it could get too bad of a result. I don't know if I then as a psychologist, I see that happening like so often, and people leaving their exercises and their like halfway or even at the beginning. This is way too common, and yes, we need to have the context around them. Yeah.
And from a perspective of trying to measure this, assess this in terms of are we giving the correct prescription of aerobic exercise, what type of things can we use to measure and should it, and Alessio mentions in a comment saying, should we put the focus on the level of pain during the exercise session to kind of measure the dosage that we're using and to see whether it's appropriate, or could we use things like questionnaires or practical tools to measure its effectiveness? What's your thoughts, David?
Okay, I think that we can use like a pain diary for assess that. What I typically do with my patient is I need to know the level of pain that my patient have during the exercise, and I like to know the level of pain that my patient have after the exercise, 24 to 48 hours after doing this. Because what we typically see is, like Nadia said before, is like we have a flare up during the exercise, and typically 24 to 48 hours after, and then typically what we see that the pains goes down and it settles again in the normal level that the patient have. um, that is always it's not a straight line. The pains of every patient knows that it goes up, it goes down some days, and we typically don't know when it is, but what we want to see is the tendency of pain. And let me explain this. if I am the patient and I do exercise today and my pain goes up to from 5 to 8, for example, and I'm 24 and 80 48 hours after it, I'm in the same level of pain. After 2 to 3 weeks, I see that now I am with this flare up for less time, for example. Instead of 48 hours, I have more pain for 24 hours. It means that I'm improving, and at that point I may be able to do a little more. But we should be very gingerly approaching this, because we don't want to burn the patient out, and anybody that is in pain wants to exercise, mm, because it's normal. If my shoulder is hurting, it's normal that I don't feel like exercise my shoulder. Um, this is what I typically do, but we can use tools of questionnaires to see how the patient is going from week to week or from month to month. But what I typically do is to monitor daily monitoring, as I may say.
Okay, thank you. That's really clear, and it kind of brings in these inevitable flare-ups and really delivering some education about what role this plays in being able to manage the appropriate prescription of aerobic exercise for people with fibromyalgia. I just want to bring it back just slightly, kind of backwards and forwards. Kate, I know you've got some real opinions on what Nadia was mentioning earlier. If you could share those.
Thank you, Nathan. That's really kind. I think Nadia gave us a great list of patient perspectives. One of the things that a lot of our Pain Alliance Europe members, I think, would say is that we've got a lot of different patient organizations bringing people together, and whether it's fibromyalgia or other conditions, people gain a lot of confidence sometimes in also talking to other people who are going through that journey. So when Nadia talked about patients who are deconditioned, who are then attempting exercise and who are seeking to understand the normalization of the aches and discomforts, getting that feedback from other people with fibromyalgia as opposed to their other deconditioned friend or their kind of healthier neighbor can be very helpful. So we would also, I would also encourage healthcare professionals to recommend that their patients engage with patient organizations and have that conversation with other patients who are on the same journey, because they have that reinforcement, and then they also have that community that helps support them when you see someone else is exercising and they're say reporting better sleep or reduced pain and some of those other factors that came up in kind of David's presentations, then I think that helps motivate people to stay in it together with motivation with each other as a community of support. Thank you.
And Lampros has just posted into the chat there, it seems to be better to focus on goals rather than the pain. And I think those community settings are really good environments for people to be able to do that. You know, they're focusing on things that matter to them, the quality of life aspects, which of course are crucial when pain seems to be or is, you know, incredibly persistent, and it's hard to determine progress based on pain experience because it fluctuates and it's kind of, you know, up and down most days. One question here from Gregorio, again, apologies, hopefully I've pronounced that correctly. What is the influence, if we were to undertake, or people with living with fibromyalgia, if they were to undertake an exercise program, does it have a positive effect on medication adherence? Perhaps, David, you might have an insight here. Is there any positive effect on the amount of medication that's taken? Perhaps that it supports tapering of medication to become more self-managed from an exercise prescription perspective?
Okay, what I've experienced working with patients with fibromyalgia, for example, is that when the patient gets better and is less in pain, uh, the dose of painkillers that they usually use uh, used to go down. So I think that that in this regard, exercise would be a good way to reduce this dose. Anyway, what I say, I always say to my patient is, although if you have the same pain, uh, doing exercise more regularly is going to improve your overall health. So it's going to be good overall. I don't know
Yeah.
if I
Yeah,
answered the question.
absolutely. And I think perhaps medication for some people, and Nadia and Kate, you might be able to input here, medication and reducing the reliance upon pharmacological interventions for fibro might be important to some people as well. So exercise prescription could assist with that. Is that something that kind of resonates from what you know about the community living with fibromyalgia?
I'm a massive advocate for exercise prescription. I think exercise is fantastic for quality of life. The feedback that I have about pain is and kind of pain medication reliance is that it's a complicated topic, and certainly while people are increasing their exercise, there's a need sometimes for some people for pain medication, because otherwise if they're trying to titrate down pain medication while they're also increasing their exercise levels, then determining the interplay of those factors, I think, and I see David nodding, can be maybe a complication that isn't always going to help give the person confidence to adhere to an exercise regime. That's my initial thought. I don't know if Nadia would want to add anything, or if David's nods mean he wants to come in.
If Nadia wants to answer, I don't.
Go ahead, David.
Okay. What I was trying to say is that not to lower the dose as we start to exercise, because when we start with some new things, typically we will have more pain. And if we start to reduce the medication that the patient use, it's only going to go worse in this kind. It's like I said, what I typically saw with patients is that we have our level of medication that we are using typically, and as the pain start to goes down over the course of the time, typically the patients tend to do in a natural way is to reduce the amount of painkiller that we need, not to reduce the dose of medication and start to exercise. It's not what I was trying to say.
Yeah, and it kind of touches on this whole holistic approach to management of fibromyalgia, and Ingrid mentions there that more than 50% of fibromyalgia people, or people with fibromyalgia, also experience IBS symptoms or incontinence urinary symptoms, which may be addressed for, or may need to be addressed for, successful engagement in exercise. So there are many other things that should be considered when it comes to exercise sort of prescription. So it's very, very interesting. So thank you so much for that. We do have one question, which I believe is in French. I've put it just quickly through a translator, so I apologize if this isn't quite correct. But go Nadia. Any points?
Can I just comment something on the IBS symptoms?
Of course.
Because and the incontinence symptoms, because this is something we do have a member organization. This is I don't remember sorry that I cannot recollect the whole title of the organization, because they do have urinary symptoms and they do have incontinence symptoms and people living with chronic pain. And this is this is a really important, and the IBS symptoms and whatever, this is a really important comorbidity for exercise. Because I mean, if everybody that's on the call stop to for a minute and we try to imagine trying to exercise, like doing anything mid-level, or I'm not going to mention high-level intensity exercise, but just mid-level intensity exercises like lifting or bending, or even trying to like run a little bit, and having incontinence, the logistics of it, or the actual difficulties of doing that, I mean, this is something we need to address, and people do not always talk about that. And how difficult would it be to have chronic pain and that particular problem? And these need to be addressed and successfully, or in a way dealt with, because this is all also this works as a demotivating thing for people to engage in exercise. And come to think of it, these are quite in the as I mentioned before, the lack of understanding that could be addressed in in another form or type of exercise. So instead of running or bending or lifting, someone could do another form of exercise, like for example swimming, because in while you are swimming, even if you lose a little bit of like being incontinent, nobody actually is going to care or is going to even pay attention to it, because you are actually swimming in the water. I mean, the logistics are there, but nobody's going to see anything.
Mhm.
So the lack of understanding and the lack of patient education and training, some things you can maybe go around and about them, and maybe you can resolve them, and some things, and these all are linked to what we are discussing. And I'm sorry for not remembering which of the people in the call said about what is happening also in our cognitive part of living with the chronic pain. And fibromyalgia is always benefiting from getting some CBT help and some resolving that thing that's connected with the way we are thinking uh, and managing our emotions and then our behavior, because it's interlinked with how we are approaching also the exercise issue.
Mhm.
I mean, whoever is thinking that if I get up from the couch and go out, I'm going to hurt myself, is not going to get up and get out to exercise. So this is a really, really ground thing to do.
Mhm. Mhm.
Just, yeah, and this was a very, really nice comment from Ingrid, Lydia. So thank you, Ingrid.
Yeah,
Yes.
yeah, and Shahid through the comments mentioned about the role of CBT, muscle relaxation
Yeah,
exercise, to kind of
yeah,
complement the prescription of
yeah,
aerobic exercise, which is
yeah,
super
absolutely.
important. Fantastic stuff. I think that comes to a natural close. Thank you so much for the questions. We probably could have gone on for another half an hour, but we have our time. But thank you to both David, Nadia, and of course Kate, who joined us a little bit later on. Thank you so much for joining us. Very, very interesting. As mentioned before, this webinar is recorded, so you can access this via the EFIC Academy platform, YouTube, social media, everything that gets to be shared. So don't forget to share this online as well, so that others can benefit from a really, really interesting discussion. Thank you again for the questions and the interaction from the audience, see them coming through there. I hope you have a fantastic day, and I hope to see you all on the next webinar. Thank you so much, guys. Take care.
Thank you, and thank you, Nathan.